Welcome to today's session. You're very welcome to today's session on our KNH UoN webinars, and we are going to be going through a very interesting discussion where we are going to be discussing about management of heart failure in children. And you're very welcome to take part and to ask your questions directly in the Q&A session. Today, I'm seeing we are around 400 and people are still joining in. So we are going to go ahead and begin. We have with us Dr. Esther Kimani, who is a consultant pediatrician. She has a special interest in congenital and acquired heart diseases in children and interventional pediatric cardiologist. She's going to be taking us through this session, and you are very welcome to interact and to ask your question through the Q&A. At the Q&A, please. So, karibu sana, Dr. Esther Kimani. I welcome you to introduce yourself, and you can go through the presentation. Thank you.
Good afternoon, everyone. I trust you can hear me. Sorry for that. So welcome to today's discussion. We'll be looking at heart failure in children. And this is our outline. We'll look at the definition, epidemiology, pathophysiology, and etiology of heart failure in children, investigations, supportive care, and medical management. So by definition, we know heart failure as reduced cardiac output where the heart is not able to meet the metabolic demands of the body. However, I like this definition that is published in the American Heart Association Circulation Journal, and it defines heart failure as progressive clinical and pathophysiological syndrome caused by cardiovascular and non-cardiovascular abnormalities that then result in characteristic signs and symptoms, including edema, respiratory distress, growth failure, exercise intolerance, and usually accompanied by circulatory, neurohormonal, and molecular derangements. So the key things is that it's a syndrome, it has cardiovascular and non-cardiovascular abnormalities, and there is a complex play of various pathways as shown. In terms of epidemiology, we do know that congenital heart diseases account for about 8 in 1,000 live births. Heart failure is associated with congenital heart disease and occurs in about 20% of all congenital heart disease patients. In large European tertiary level registries, heart failure has been shown to occur in about 1/3 of all cardiac admissions. And when you look at the general pediatric inpatient admissions, about 24%, roughly 1/4 of children at any given time did have heart failure. In terms of age, 70% of congestive heart failure in children occurs during infancy, that's during the first year of life. So we'll look at the pathophysiology, and we'll start here. I put this up because this is a very important pathway, the renin-angiotensin-aldosterone pathway, because this is what then triggers the neurohormonal and circulatory derangements that then give you the symptoms of heart failure. We do know that angiotensinogen is converted to angiotensin 1, and renin is the enzyme that does that, and then angiotensin 1 is converted to angiotensin 2 by the ACE enzyme in the lungs, and it is angiotensin 2 that then has a lot of effects on various end organs. In the heart, angiotensin 2 will cause cellular hypertrophy. It will cause myocardial apoptosis and fibrosis. It causes inflammation. It does give you positive ionotropy, but at the same time, you end up with coronary vasoconstriction, and it's also very pro-arrhythmic. All right, and in the blood vessels, you end up with vasoconstriction, you end up with inflammatory cytokines, you end up with endothelin secretion, which is another potent vasoconstrictive agent. And lastly, in the brain, it stimulates a production of the sympathetic, activation of the sympathetic nervous system. All right, in the adrenal glands, aldosterone is also secreted. Now, with that in mind, what happens when you have heart failure? You will have a reduction in cardiac output, and this then causes a feedback loop, and you have stimulation of the renin, angiotensin, aldosterone system. You will end up with an increase in sympathetic tone. You will end up with increase in angiotensin, which we've seen is a potent vasoconstrictor. You will end up with increase in mineralocorticoid production. So you have salt and water retention. And you also have increase in inflammation and inflammatory cytokines, specifically tumor necrosis factor, which then contributes to cardiac cachexia, okay? So usually when you get this initial increase in sympathetic tone, you will end up with tachycardia and enhanced contractility. So in the initial phases, this pathway actually is beneficial. However, in the long run, what happens is that you end up with an increase in myocardial work, you end up with increased myocardial oxygen consumption, and you also end up with cardiac remodeling, which is here. Now, cardiac remodeling is not a good thing, all right? What remodeling means is that your heart, especially the left ventricle in particular, is elliptical in shape. When it remodels, it ends up being spherical. It ends up being more rounded. And that's not a good thing because a rounded ventricle has poor contractility and it is less compliant, okay? And in the face of cardiac remodeling, you also end up with increased filling pressures. You end up with systemic and pulmonary edema. You get redistribution of blood from skeletal and splanchnic circulation. And this results in tissue hypoxia and comes back to give you cachexia. Since you start losing lean mass. There are some small pathways, mechanisms that try and overcome this. And usually this will be our beta natriuretic peptides, that's ANP and BNP. You also have a slight increase in your growth hormones and IGF-1. However, this usually does very little in terms of overcoming this pathway, okay? So having that in mind, what then would trigger heart failure in children? And how I would like us to think about it is that we have several mechanisms, we have several ways in which the heart fails. So one of the ways a chamber can fail is pressure loading, okay? So if you put excessive pressure on a ventricle, it will fail. All right. If you increase the afterload of that ventricle, it will fail. So pressure loading lesions, this include stenotic lesions. So in children, coarctation of the aorta is an important pressure loading lesion. You have critical aortic stenosis, and you have severe and critical pulmonary stenosis that then cause pressure loading of your right ventricle, okay? The other way in which a chamber or ventricle can fail is volume loading, all right? And these are the lesions we are more familiar with. You have ventricular septal defects, you have atrioventricular septal defects, AVSDs, you have PDAs. Basically, what they do is that they present the chamber, usually the left-sided chambers, with excessive preload. And if you look at the Frank-Starling curve, you know, the heart can only stretch up to a certain point beyond which it will no longer stretch and it will fail. And that's the other way in which chambers will fail. And lastly is insufficiency. And insufficiency can be because of a primary myocardial inefficiency. And I would like to think of that as your primary cardiac cardiomyopathies, Or you can also have valvular insufficiency, acquired valvular insufficiencies, and congenital valvular insufficiencies, all right? All these mechanisms interplay, and they're either genetic or they can be acquired, okay? So all the causes will fall within this spectrum. So the sources of heart failure, you can have a structurally normal heart, and you can have a structurally abnormal heart. And this is actually one of the biggest differences between heart failure in children and in adults, is that we do see a bit more of the structurally abnormal hearts resulting in failure. So when you look at a normal heart, you can have a primary cardiac pathology, and we've talked about cardiomyopathies. We'll mention more about that. Myocarditis, myocardial infarctions. It can occur in children, especially in the face of Kawasaki disease, okay? And other conditions such as Al-Kappa, when you have an aberrant left coronary artery arising from the pulmonary artery. We can have acquired valve disorders, common in our setting, in rheumatic heart disease. And then you can have other non-cardiac causes of heart failure. And this include anemia, they include sepsis, all the way to muscular dystrophies and endocrinopathies, including hypothyroidism, all right? So these are causes of heart failure in a structurally normal heart. The other big group of malformations are cardiac structurally abnormal hearts, where you'd have shunt lesions, as you've said. Basically, they will give you volume loading of your chambers, VSDs, PDAs, aortopulmonary windows, atrioventricular septal defects. We've talked about that. Then you also have valvular regurgitation. And note, in children, you can have both acquired and congenital valvular abnormalities. Of course, in the acquired group, the leading would be the rheumatic heart processes. You also have inflow obstruction. By inflow obstruction, this is basically the left ventricular inflow obstruction. So you'd have contraatriatum sinistrum, which is a form of an abnormality in the pulmonary venous drainage into the left atrium, pulmonary venous stenosis, and mitral stenosis. Mitral stenosis can be congenital and acquired in children. And lastly, you'll have outflow obstructions, and we've talked about this. These are the ones that will give you pressure loading of your left ventricle. I will mention a bit about cardiomyopathies because they are an important cause of heart failure in children. So there are four main types of cardiomyopathies. We have dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, and non-compaction left ventricular cardiomyopathy. So in the panel on the right, this right here is let's see, let's get a laser. So this is a normal heart, okay? In anatomical position, right atrium, right ventricle, and left ventricle. And you can see it's a nice normal heart. In this top right panel, you can see the left ventricle is very thickened, okay? So this is an example of a hypertrophic cardiomyopathy, all right? In the bottom left, you can see that the chambers on the up part are bigger than the ones that are on the smaller part, all right? So the atria are much larger than the ventricles because the ventricles are not able to expand very well. So this is an example of a restrictive cardiomyopathy. And lastly, the bottom right panel is an example of dilated cardiomyopathy. You can see that very dilated left ventricle. Dilated cardiomyopathy is important because 90% of cardiomyopathies in children actually, and they represent about a fifth of all cases of heart failure. But interestingly, the prevalence of heart failure in children with DCM ranges from 58 to 80%. And this is as per large European registries. So what's the clinical presentation of heart failure? It depends on the age, and it's important to bear that in mind. So broadly, newborn infants and toddlers, children who cannot talk for themselves, usually would have, they would present with poor weight gain, And if you look at their growth velocity, it's either flattened or getting a downward trajectory. They'd have decreased oral intake. They'll have increased work of breathing. These are children who will be very fasting, and there will be diaphoresis, and diaphoresis will be more remarkable during feeding. All right. And the signs of heart failure in these children would include tachycardia, tachypnea, grunting, flaring, wheezing. They'd have a gallop rhythm, displaced apical impulse. They'd have hepatomegaly and poor perfusion. All right. So in all the children, you then have they would come in and they'd say, the child would say they have exercise intolerance. So it's a child probably who was active in school and all of a sudden they are no longer active, or could play 90 minutes of football and now he can only play 10 minutes of football and he has to sit down and take a break. All right. So orthopnea, fatigue, paroxysmal nocturnal dyspnea, poor appetite and cough are other symptoms. And the presentations are as listed there. There have been several classifications, clinical classifications of the severity of heart failure in children. The commonly used one is the New York Heart Association, which is good for adults and adolescents. However, for children, we tend to use a modified Ross classification, and it has 4 classes. The first class is a child who is asymptomatic, all right? Class 2 would be, an infant who has mild tachypnea and they would have diaphoresis with feeding. And in older children, they at this point would have dyspnea on exertion, usually moderate exertion, okay? In class 3, you'd have marked tachypnea and diaphoresis in feeding. However, the hallmark of class 3 is prolonged feeding times, and at this point they start getting growth failure. And in older children, they get marked dyspnea on exertion, basically a child who gets mildly dyspneic on mild exertion. And then class 4, they have all the symptoms, including tachypnea, retraction, and grunting at rest. So what investigations? How do we investigate then heart failure? There are several things, you'd have lab tests, you'd have other modalities. We'll start with the lab tests. So you do a full blood count. And one of the things you must exclude is anemia, because remember, anemia is one of the causes, the non-cardiac causes of heart failure. You do your urea electrolytes and creatinine. You can find that these children will have hyponatremia. Remember, they have an increase in ANP and BNP, which are natriuretic peptides, so they'll have enhanced natriuresis. They will have edema, so they get a dilutional component of hyponatremia. And some of them might actually be on diuretics, which can give you hyponatremia and hypokalemia. They might have elevated urea and creatinine because of the hypoperfusion of the kidneys. LFTs, you might find they have some transaminases, also because of congestive hepatopathy, and some of these children might actually even present with frank hyperbilirubinemia. Is there a role for cardiac markers in children? Yes, there is a role. The markers that have been studied are the BNP and NT-proBNP, our natriuretic peptides. They have been shown to be elevated in children with heart failure, and they correlate very closely with the Ross and the New York Heart Association classification severity. And lastly, it's always good to check thyroid function tests, because remember, hypothyroidism is actually one of the causes of heart failure. It's one of the causes of dilated cardiomyopathy, and also hyperthyroidism can also give you a high output state and heart failure. ECG is important because ECG can tell you whether you have an arrhythmia as a cause of heart failure, but ECG can also indicate to you the underlying pathology, okay? Children with heart failure will more often than not be tachycardic, okay? So having an ECG would also be, you'd also be able to tell what chamber of the heart is affected, For example, this is a 16-year-old who was, we've been following up, being treated for a valvular heart lesion, but you can tell from this ECG, there is evidence of significant right ventricular forces. We have right atrial dilatation. This young lady had severe pulmonary hypertension and currently is being investigated for an idiopathic pulmonary arterial hypertension. So ECG is important in that respect. And sometimes the ECG can look as chaotic as this. You can see here, these are delta waves in our precordial leads, actually in all the leads, and it's an irregular rhythm, wide QRS complex. This is basically an atrial fibrillation in the setting of Wolff-Parkinson's-White syndrome. Okay, so ECG is important because this is one of the lesions that can precipitate heart failure in children. Chest X-ray also would tell you a few things. Obviously, you'd get cardiomegaly, and always make sure that the X-ray is of good quality. You know, it's not rotated, it's of good inspiration, and it's of good exposure. All right, so you'd have cardiomegaly, and there are other chest X-ray features that are specific to certain lesions. Okay, so it's important to look at the chest X-ray. And lastly, echocardiography is key in defining heart failure as the underlying cause of heart failure. This, was an echo of a 3-week-old. Okay, it's not playing. Echo of a 3-week-old who presented to us with heart failure. And you can see that right there. There's a coarctation. So that was a coarctation of the aorta, which was a cause of heart failure. And this baby was taken in for surgery. So how do we manage heart failure? Before we talk about management, perhaps we should define what the treatment goals for heart failure are. So the first goal is to eliminate the underlying cause. And then the second goal is to control symptoms and disease progression. And how do we do that? We want to maximize on cardiac output. We want to increase tissue perfusion while minimizing on myocardial oxygen consumption. Okay. So we'll start with supportive measures. Of course, the first thing you do is you'd want to prop up this child in bed. Okay. Secondly, you would want to optimize on nutrition. All right. So for children with heart failure, remember we said they're at catabolic, they're in a catabolic state. So you would want to aim for slightly higher kilocalorie intake than usual. So in infants, you want to aim for 150 kilocalories per kilo per day. And in the older child, you want to aim about 25 to 30 kilocalories per kilo per day. All right. You would want to give this feeds as small, frequent feeds. And if you're to break down your kilocalorie intake, or rather look at your macronutrient intake, you want to give carbohydrates, certainly not more than 6 grams per kilo per day, lipids at 2.5 kilograms per kilo per day, and proteins at between 1.2 to 1.5 grams per kilo per day. All right. So nutrition is very important in these children. We also have supplementation of other micronutrients. And we usually supplement carnitine in dilated cardiomyopathies because one of the causes of DCM is carnitine deficiency. So routinely we would give carnitine to our DCM patients. And lastly, not listed here, you would want to look whether this child has other causes. So look for anemia, treat the anemia, supplement iron, and also look for rickets and supplement your calcium and vitamin D as well. The third supportive measure is oxygen, all right? In the absence of cyanotic heart disease, oxygen usually would be indicated, and you would want to aim for an SpO2 of about 92 to 94 in these children, all right? And of course, there is the role for restricted fluid intake, okay? In terms of medical management, I put this up here. This is from the American College of Cardiology. These are the heart failure guidelines in adults. The reason I put this here is because we do not have a lot of trials in children, and most of the heart failure guidelines in children have actually been borrowed from adult guidelines. Okay, and what you can see here is that they emphasize use of ACE inhibitors and beta blockers, and certainly use of diuretics that runs across all the classes. And I'd like you to compare that. These are the Canadian Cardiovascular Society guidelines. And you can see they also do advocate for a lot of, ACE inhibitor, beta blocker, diuretics, and digoxin. And basically, we look at each of these agents and the evidence behind using these agents. So the first drug or the first agents we use a lot is diuretics. And we have several types of diuretics. We have loop diuretics, aldosterone antagonists, and thiazide diuretics. In children, we commonly use furosemide and spironolactone. Those are the ones that are readily available in our setting. And what diuretics do is that they reduce pulmonary and systemic venous congestion. Diuretics also improve ventricular performance by reducing or optimizing preload. Okay. Spironolactone has an extra benefit in that it inhibits myocardial fibrosis and it actually attenuates myocardial remodeling. All right. And in the randomized aldactone evaluation study of adults with severe heart failure who are randomized to receive spironolactone, there was a 30% reduction in the risk of death and a decreased frequency of hospitalization for worsening heart failure in the patients who received spironolactone. Okay, so this is one, certainly this is part of the evidence that we leverage on to use diuretics and aldactone antagonists in children. We do not have any randomized trials looking at use of diuretics in children, so we borrow heavily from the adults. The second drug we use a lot is digoxin. And as we all know, digoxin is a cardiac glycoside. Its principal mechanism of action is inhibition of the sodium-potassium ATPase pump. And then this in turn promotes calcium influx. And then this gives you a positive ionotropic effect. Digoxin also has parasympathetic mechanisms, and it usually would lower your atrioventricular node rate and even your SAM node rate. And in that respect, then it gives you a negative chronotropic effect. And it does this without affecting your blood pressure, which makes it a very good agent to use in children. Is there data promoting the use of digoxin in children? We do not have any clinical trials that promote use of digoxin in children. And in fact, the adult trials that have looked at the use of digoxin, we had the Digitalis investigation group, the Radiance trials, all showed that digoxin did not reduce mortality in adults with severe heart failure. And in fact, there was a slight increased risk in arrhythmic deaths in adults who received digoxin. So one would ask, why then would we use digoxin in heart failure in children? Should it be continued or relegated to the history books? And this is a very interesting article that was published in the Annals of Pediatric Cardiology that then discusses the utility of digoxin in management of heart failure in children. And in this article, there is consensus and level E evidence, expert opinion, that digoxin has a big role in heart failure in children. One, in children who have got left ventricular systolic dysfunction, digoxin plays a paramount role given the fact that it has a good positive ionotropic effect. Two, in children who have valvular disease with severe systolic dysfunction, digoxin has a role. In children who present with tachyarrhythmias, specifically atrial fibrillation in the presence of valvular disease, digoxin does have a role. Okay, and lastly, remember a part of heart failure management, we want to work on reduction of myocardial oxygen consumption, and part of that is reducing the heart rate. And as we've clearly, we've said here, digoxin has a negative chronotropic effect. So it's very good in lowering the heart rate without affecting blood pressure. And in that way, it promotes left ventricular filling by increasing diastolic filling times. So you have increased left ventricular and diastolic volumes that then gives you an increase in your cardiac output. It also promotes coronary perfusion because by increasing your diastolic times, you increase the time that you get to perfuse the myocardium via the coronary circulation. So yes, digoxin is another cornerstone drug that we use in management of heart failure in children. ACE inhibitors. So the common ones that have been investigated for both adults and children are captopril, lisinopril, and enalapril. And in adults, ACE inhibitors did show improved functional capacity. They showed fewer hospitalizations, and they actually showed decreasing mortality in the adult population. And this is one of the older popular trials done by the Solvit investigators published in the New England Journal of Medicine. And this trial basically randomized adults with severe left ventricular failure to receive placebo and enalapril. And you can see, looking at this Kaplan-Meier curve, there was a reduction that was statistically significant in patients who received enalapril vis-a-vis placebo. There have been smaller trials in children. There is one here by Moma et al. That looked at the utility of ACE inhibitors in children with dilated cardiomyopathy and children with valvular insufficiency post-op. And what they were able to demonstrate, though it was a small study, is that ACE inhibitors induce a small increase in left ventricular ejection fraction, and they actually promote systemic blood flow in children with left ventricular dysfunction, mitral regurgitation, and aortic regurgitation. And for that reason, ACE inhibitors have also found a place in management of heart failure in children, especially children with those three particular lesions. Beta blockers, Cavetylol, metoprolol, and bisprolol have been studied. So initially, many years ago, people would shun away from using beta blockers in heart failure. Certainly in chronic heart failure, beta blockers have found a great place and are currently a mainstay in management of heart failure in adults. And these are the guideline statement by the International Society of Heart and Lung Transplant, which says that following adult heart failure guidelines, it is reasonable to consider beta blockers in asymptomatic children with systemic left ventricular dysfunction. And part of the benefits of beta blockers is that they attenuate left ventricular remodeling. In fact, they attenuate that chronic sympathetic nervous system, activation. And they also improve chamber function by upregulating beta receptor density, okay? We do have a beta blocker, Cavetylol, has been studied in children with heart failure. This was a study done by Shadi et al. That looked at 161 children who were randomized to receive Cavetylol or placebo as an adjunct therapy. Okay, so they're receiving other drugs and Cavetylol or placebo was added to their therapy. And they then looked at their endpoints, which were mortality or hospitalization. And you can see from this chart that, yes, if you look at all-cause mortality, Cavetylol seemed to favor, seemed to reduce all-cause mortality. However, it was not statistically significant, had a p-value of 0.55. And even when you looked at cardiovascular mortality, it seemed to favor Cavetylol. However, this was not statistically significant. And the conclusion of this particular trial, which was very surprising, was that Cavetylol did not have a significant effect on primary endpoints in children and adolescents with symptomatic heart failure due to systemic ventricular dysfunction. So part of the reason why these findings were as they are is this was a very small trial, only had 161 children. So many people felt it was probably not powered enough to suggest otherwise. But having said that, Cavetylol is still used a lot in children, especially in the face of left ventricular dysfunction, and it is used as an adjunct therapy. Okay. What's new, at least new to children, is we have this new agent, Evadrin, has been used by adults, but is now coming into the pediatric scene. Evadrin is a heart-lowering agent that acts by selectively inhibiting the cardiac pacemaker cells. And what it does is that it blocks the mixed sodium-potassium cells, and you end up, as you can see right here in this blue box labeled Z, you end up with an increase and slowing down of diastolic depolarization, and you end up with a lower heart rate, okay? And the lower heart rate is good for heart failure, okay? And it does this by acting on the SA node, and it has no effect on blood pressure, has no effect on cardiac conduction, has no effect on myocardial contractility, and has no effect on ventricular repolarization, meaning that it does not predispose you to arrhythmias per se. And the initial trials, of course, were done in adults. This was a shift trial published in the Lancet in 2010. And basically, it was a large trial that looked at over 6,000 adults. And these adults were randomized to receive Evadrin or placebo, okay, as add-on therapy. And what they were able to show right here, as you can see in this Kaplan-Meier curve, is that there was a reduction in primary composite endpoint of hospitalization and of worsening heart failure and cardiovascular death. Okay, so Evadrin was shown to be, really good and in worsening those out, in reducing those endpoints. Is there evidence in children? Yes, there is. This is perhaps the only study that I came across. It was a small study published in 2017 in the Journal of American Cardiology, and they looked at 116 children. These children had dilated cardiomyopathy, DCM. So the primary endpoint of this particular study was a 20% reduction of heart rate from baseline without bradycardia, okay? And were they able to achieve these endpoints? Yes, they were. 70% of children on Evadrin did achieve the primary endpoint. And it was actually a statistically significant reduction in heart rate. And when they looked at their secondary endpoints, so the secondary endpoints were, do we have a reduction in heart failure status? And they used the New York Heart Association classification. Do we have an improvement in ejection fraction? And lastly, was there a perceived improvement in quality of life? And as you can see here, so the blue is a Evadrin curve. There was a significant improvement, at least in left ventricular ejection fraction shown here. And it was statistically significant, almost a twofold improvement from placebo. And therefore, the conclusion of this particular study was that Evadrin is safe in reducing the resting heart rate of children with chronic heart failure and dilated cardiomyopathy. In our setting at KNH, I do know we have used Evadrin as an adjunct therapy for children with DCM who have had, poor clinical progress or poor, left ventricular systolic recovery. So we've added Evadrin to part of their treatment regimen. So what are the other modalities? We have simple sympathomimetic amines, that's dobutamine and dopamine, and also phosphodiesterase type 3 inhibitors, which is milrinone. These two groups of drugs usually would be used in a pediatric intensive care setting in the face of severe heart failure with low cardiac output states. And what your dobutamine and dopamine do is that they will increase your cardiac output and decrease systemic pulmonary vascular resistance. However, they're very, arrhythmogenic, okay? They can give you lots of tachycardias, and they can even precipitate some supraventricular tachycardias. So that's the downside of using them. Milrinone is an excellent ionodilator, however, can only be used in a very sick child in the PICU setting. We have a newer agents, angiotensin receptor neprilysin inhibitors, or ARNI. This is has been studied in adults, where neprilysin inhibitor and valsartan were used, and this did show a significant improvement in mortality, risk of hospitalization, and improvement of symptoms. We have no data, no pediatric data of use of ARNI, and certainly, to the best of my knowledge, we have not started using this in our population. Other modalities of treating heart failure, there is a role for device therapy. So there is a role for ICDs, which is an implantable cardiovascular defibrillator, usually used in children with very severe left ventricular systolic dysfunction as a secondary prophylaxis from ventricular arrhythmias. And we also have cardiac resynchronization therapy used in children still with left severe left ventricular and systolic dysfunction with bundle branch block, and there are other indications for CRT. We don't use it a lot, at least to the best of my knowledge, but those are options that are out there. In the developed world, we can use left ventricular assisted devices. That's an LVAD, and usually an LVAD would be used as a bridge to finally a cardiac transplant. Okay, so in our population, then one would ask, what would be the practical approach? And I really like this graph because it sort of gives you a way to approach a child with heart failure. So if it's an acute decompensated heart failure of known etiology, you would want to start with your diuretics and with your ionotropes. In our setting, we use digoxin, okay? And you can add on your ACE inhibitors and your beta blockers if required. And if you get hemodynamic recovery, then you pursue etiology-based management. If it's a congenital heart disease, then you would want to have a surgical or an interventional correction. Or if they are not amenable to that, then you follow the palliative route. If it's a de novo acute heart failure of an unknown etiology, you then want to find out, is this an extracardiac cause or is it a ductal dependent lesion? Ductal dependent lesions would present mainly in the neonates. And if it is a ductal dependent lesion, then the route you would follow is a prostaglandin infusion with ductal stenting or surgery. And if it's an extracardiac cause, then you tailor the management appropriately. For the very small population of children, those who have got dilated cardiomyopathies or other forms of cardiomyopathies with myocarditis, you would want to put them on heart failure medical therapy, as we've talked about, and follow them up. In the event that a child does present with end-stage heart failure, there is room for what we've talked about, left ventricular assisted devices, LVADs, and ideally a cardiac transplantation. So perhaps this is where we would all be focusing on, okay? As I wind up, heart failure is a complex syndrome. And in children, it has a lot of heterogeneous etiology and heterogeneous presentation. And unlike adults, heart failure in children is primarily due to structural heart disease and reversible condition, which is great because then it means these lesions are amenable to definitive therapy and to short-term aggressive therapy. And lastly, as you've seen, a judicious balance between extrapolation of adult heart failure guidelines and the development of child-specific data on treatment represents a wise approach to optimize management in these challenging fields. Those are my references, and I think that's the end of my discussion. Thank you.
Thank you very much, Dr. Kimani, for that elaborate presentation. Indeed, you've broken it down, this complex just as I said, is a complex syndrome, management of heart failure in children, and you've been able to just break it down very well in these past few minutes. So we really, really appreciate that. For our participants, thank you for staying with us. You can see some few of your questions in the Q&A section, and maybe we'll just get it right into that. So there's a question here about the medication between captopril and enalapril, which has better control in children.
Okay, thank you for that question. Both those two drugs have been studied in children, and really at the end of the day, it's more of provider preference, but either is good.
Thank you for that. The other question is, what is the typical regimen for heart failure in children in Kenya? We also have the 3 pillars of heart failure treatment in adults for children. This is from Brian Odongo.
So thank you for that question. I think we've answered that going through the discussion. So we said, so typically you would want to check on your, supportive management, which we've talked about, okay? And then for medical management, you would want to look at your diuretics, which basically form the foundation of most drug regimens. There is a big role for digoxin in children, unlike in adults. So those two would be the 2 key drugs that we would use. And then depending on the lesion of the child that the child has, as I've mentioned, if it's a dilated cardiomyopathy, if it's valvular regurgitation, mitral regurgitation, aortic regurgitation, there's a role for enalapril or ACE inhibitors. And then, so that would come in as an add-on therapy. And then lastly, you would add on your beta blockers and Evadrin if necessary. So typically that's how, our regimens would look like.
Thank you for that. Yeah, indeed, some of these things have been covered, but we'll need to go over them for those who came in late. And we still appreciate your question. You can still keep them coming. And we've gone through the elaborate presentation of all the way from definition, the pathophysiology, the causes, the clinical presentations, laboratory tests, and an elaborate presentation on the treatment goals and the medication. Another question here is, what is the prognosis? Can a child with heart failure live to adulthood?
Thank you for that question. It would depend on the underlying lesion. Okay, so yes, they can live to adulthood, and certainly it would depend on the underlying lesion. For children with cardiomyopathies, in our setting, they tend to have an excellent prognosis. Children with shunts that are surgically amenable, they have a great prognosis. Children with single ventricle physiology would depend on the type of specific lesion that they have. So that will be a 50-50. But generally, most of the heart failure in children has a good prognosis. Yeah.
That's encouraging. Another question here from Freda Kosgei. You mentioned that one of the signs of heart failure is wheezing, which could easily be mistaken for asthma. How could this be differentiated for the correct diagnosis?
That is very true. And as we've seen, if a child comes in and they have wheezing, you have to take a very good history. If it's an infant, is there a history of diaphoresis during feeding? Do we have growth retardation, which is another important feature? What are the other clinical findings? Do we have hepatomegaly? Is a child having tachycardia? Is a child having tachypnea? So if you have wheezing in the background of all these other features, certainly you would know that this is not just a simple asthma, okay? And then from there, you look at your chest X-ray. you will see cardiomegaly, you will see increased pulmonary vasculature, okay? So in that way, you would be able to differentiate as simple as asthma, because in asthma, you do not expect cardiomegaly and you will expect hyperinflation. But in heart failure, the chest X-ray feature would be different. So based on your history, your examination, your chest X-ray findings, you're able to easily differentiate between the two.
Thank you for that answer. We also have a lot of participants who are really saying this is a wonderful presentation and really are just appreciating the way you've broken it down and just the whole explanation on heart failure in children. One other question, how can we better manage fatigue in heart failure in children? From Lukwago.
Thank you, Nicholas. That's a good question. So we've seen the cause of fatigue usually would be, hypoperfusion of your end organs, okay? So initiating medical management, your diuretics, improving ionotropy, okay? And treating the underlying condition. If it's a failing valve, surgically amenable, follow that channel. If it's a shunt or an obstructive lesion that can be surgically corrected, follow that channel. And then lastly, optimizing on nutrition, as we have talked about. Thank you.
Thank you. The other is maybe just to go over slightly again. You said 90% of cases are due to dilated cardiomyopathy. What are the causes? I think we've covered this, but maybe you can highlight for somebody who missed it.
So thank you, Peshu. I did not say that. What I said was that cardiomyopathies, 90% of cardiomyopathies, cardiomyopathies as a group of illness in children, 90% of the time would be due to dilated cardiomyopathy, okay? So what are the causes? There are very many causes of DCM in children. I think that is a lecture in and of itself. However, just to highlight a few, we have genetic causes, which account for about 30 to 50%, okay? Genetic causes would mean you have genetic gene mutations, either in your sarcomere proteins, in your desmin proteins, in your troponin proteins, okay? So those genetic mutations can give you DCM. Other causes would be metabolic disorders, glycogen storage disorders, okay? Long chain fatty acid oxidation disorders, which we've talked about, carnitine deficiency, which we've talked about, okay? So those are genetic predisposition. Then you have a group of other causes which include infections, and the commonest would be Coxsackie virus, enteroviruses, adenoviruses, retroviral disease, etc. All right. Endocrinopathies like hypothyroidism can cause DCM. All right, and the list is endless. So that's just a summary of the causes of DCM. Perhaps we should have a talk on cardiomyopathies soon.
Indeed, we should. It's a really wide topic. Another one here from Julia Sotiambo, who is appreciating the presentation and saying, talking about fluid restriction in CHF in children, and if need be, which type of fluid do we give in this condition?
That's a great question. So usually, if you can go the enteral route, the better. All right. So enteral feeding is preferred. However, when that is not possible, you would go for an isotonic fluid. All right. And an isotonic fluid the best would be Ringer's lactate. All right. And of course, you add your 5% dextrose to take care of the hypoglycemia. All right. So yeah, that's the fluid that we would go for. But if you can do enteral feeding, the better.
Thank you. Enteral it is. There's one from Michael Karaoke. Can we categorize heart failure in children using the formulas listed there? And why are CCBs recommended in heart failure due to hypertension and not any other cause? And the third question on, can Evadrin replace Digoxin?
All right, thank you, Michael. Those are great questions. So your first question, can we categorize heart failure into reduced ejection fraction, moderate ejection fraction? I think I've seen here. Oh boy, it has disappeared. And preserved ejection fraction. So those are classifications used in the adult population, okay? And the assumption is that you have a structurally normal heart. This classification will not apply to children because, as we said, a greater percentage of children with heart failure will have a structural lesion, okay? So they'll either have a shunt, or they'll either have an obstructive lesion, or they will have a leaky valve, all right? And therefore, this classification cannot be used in children, all right? In the face of dilated cardiomyopathy, as part of the definition, you would have a reduction in ejection fraction, okay? So that still does not apply. To your second question, why are CCBs recommended in heart failure due to hypertension and not any other cause? Hypertension in children is not very common. And in fact, if you find hypertension in a child, from a cardiovascular standpoint, one of the things you need to rule out is coarctation of the aorta, okay? And the other would then be renal causes of hypertension. We do not use a lot of calcium channel blockers in heart failure in children. They do have a very small role, I know, in severe pulmonary arterial hypertension. After several, you've done several investigations that's shown that you have reversibility of your pulmonary vascular bay. That's the only role they have. But in the face of heart failure in children, they do not have a role. And can Evadrin replace Digoxin? So all the clinical trials that have looked at Evadrin have used it as an adjunct therapy to a beta blocker, okay? And the principal role of Evadrin would be to reduce heart failure. Can it replace Digoxin? At this point in time, I believe it cannot, because remember what we said, it has a great heart rate reducing properties, but it has absolutely no effect on ionotropy. In children, when we use Digoxin, we want that positive ionotropic effect. So you cannot replace Evadrin for Digoxin, and you cannot use Evadrin as monotherapy. In all the trials, it's been used as an adjunct therapy.
Thank you, Dr. Kimani, for that elaborate response. We still have a few questions, especially in regard to the medications and what to use. There's one asking a dose of aldactone in children. That will depend on the kgs for the children, but you can comment on that. The other one you can combine it with any preference of which ionotropic to use in hemodynamically unstable patients.
So the dose, the dose of can you hear me? So the dose of aldactone in children is 1 to 3.3 milligrams per kilo per day. That's a dose. Ionotropic use in children in hemodynamically unstable patients. We have listed there, I think I mentioned this, we talked about dobutamine and dopamine and milrinone. Those are the ones that are used from a heart failure standpoint. And the reason they're preferred is because they do not increase myocardial oxygen consumption. You can use epinephrine and not epi, but of course be aware that it will increase myocardial oxygen consumption.
Thank you. The other, sorry, let me go back to the question. There was a question about the cardiothoracic ratio. Yes, is the cardiothoracic ratio of 50% reliable in infants where the AP view of the chest X-ray is likely to affect the magnification of the heart?
That's a great question. So in children, in infants, you want to look at a cardiothoracic ratio of more than 60%. And above that, it's more than 55%. And that takes into account that magnification of the heart.
Mm-hmm. Thank you. And a comment, please comment on the blood transfusion procedure in a child in cardiac failure.
That's a great question. So you would want, what typically we do from our guidelines is you give packed cells if possible. You would want to start at 10 mL per kilo of packed red blood cells. You would want to transfuse it over a slightly longer period, probably 3 to 4 hours. And you should, ideally, you can give Lasix about 1 milligram per kilo start at the end of the transfusion.
Thank you. Thank you, our participants. We're seeing also a lot of comments on the great presentation and great comments. And we'll find a way of how to share these slides. A lot of people asking for the presentation. And maybe from our list, we'll be able to see how we can be able to share some of this information with you. Let's see one more question. Well-elaborate presentation. Could an uncorrected ductus arteriosus lead to heart failure?
The answer is yes. If it's a large uncorrected ductus, then yes.
Thank you. And I think that actually brings us towards the end, because I think we've answered most of these questions, especially in regards to the medications. Let's see if we have any raised hands. Maybe since we have a bit of a few minutes, we can be able to maybe get some of the participants asking. So we have Lillian Moutier. Are you there? So would you still like to ask your question live? Maybe from the resource center, from the host, you can enable Lillian Moutier to just unmute and be able to ask her question. Or James Alai. We have Lillian Moutier, James Alai, who have their raised hands. If you can just quickly ask your question, unmute and ask your question. Seem not to be able to get them. Otherwise, we are now winding up on today's presentation, and today we've been having a discussion on management of heart failure in children, and we've gone through all the way from the basics up to the management level, all the complex management, the new interventions that are coming into place, the new medication, and we really appreciate Dr. Esther Kimani for taking us through in a very, very elaborate way. We'll now just have maybe the last comments from her before I brief you on what is coming up here. Dr. Kimani, you can give us your winding comments.
Okay, so thank you very much. This was a great discussion, and thank you for listening.
Indeed, thank you. We'll sure invite you again, because this is not the end of it. There's still a lot of information and you need to speak it in. So we really appreciate. So as you can see on our screens, we have a symposium coming up, a KNH UoN Webinar Perinatal Health Symposium. And you really don't want to miss this. It will be a 3-day symposium starting tomorrow in the afternoon at the same time from 2 p.m. all the way to 5 p.m. 5 p.m. 30 p.m. We'll be discussing issues to do with perinatal health, and we have great speakers, as you can see. So be sure to register just the same way you registered for this session. Be sure to register and not miss out on these three days as we discuss matters perinatal health. The other thing, we've had a lot of questions about how to get the CPD points. These ones you'll be able to, if you've not gotten your CPD, maybe 2 weeks down the line or 3 weeks, kindly email cpdknhpharmacy@gmail.com or cpd or knhcpd@pharmacy. Let me get that again. KNH. Wait, just a minute. I get that. knhcpd@gmail.com. Especially for the pharmacist, you need to use the self-reporting icon at the the portal. So you self-report. You just put in the name of the session that you are attending, and afterwards the list will be sent and for confirmation, and you'll be able to get your CPD. But if you still have challenges, do reach out. Also for the presentation, if you need the presentations and nonsense, you can still reach out through the same emails so that you can see how to get that. Otherwise, we are now at the end of the session. We appreciate you for staying with us. Let's join in tomorrow. Have a lovely afternoon. My name is Dr. Agnes Karingo Karume from Kenyatta National Hospital. Do have a lovely afternoon. Thank you.
Thank you.